we're looking today at why patients and families might request aggressive medical management despite poor prognosis or low hope of recovery. I'm going to do a quick Indigenous land acknowledgement first. I'd like to acknowledge the land on which we gather is the traditional territory of the Haudenosaunee, and most recently the territory of the Mississaugas of the New Credit First Nation. This territory was the subject of the agreement between the Iroquois Confederacy and the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. This territory is also covered by the Upper Canada Treaties. Today it is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work in the community on this territory, and it's our collective responsibility to pay respect and recognize this land as traditional territory. Just some quick thanks to our former fellows and current fellows for some lit review support on this talk. A couple of them helped with regard to the Semitic monotheistic traditions, which is actually something we're going to skip because we don't have time, with regard to artificial nutrition and hydration. But we are going to talk about that topic, and our current fellows with regard to the topic in general. So I chose this topic. I gave a survey to the Durham Regional Cancer Center. I serve the Durham region, giving them several topics to choose from. They overwhelmingly chose this topic. Interestingly, on this topic, I have the most people getting in touch with me in advance who want to talk more about it, and the most people have been attending at our other sites. So it's not me. It's very, very popular and a very important and challenging type of issue. It often appears in our clinical cases as ethicists and in other contexts and other roles too. A Canada-wide survey of 255 healthcare providers in intensive care units, 95% of nurses and 87% of physicians reported the use of quote-unquote futile care, so we can trouble that term. Most often the request for such care comes from the family. So in general, even despite the title of the topic, I'm going to be talking mostly from the substitute decision maker perspective because there seems to be in general, and you may or may not agree with me, less distress when a patient requests such things capably for themselves versus someone doing it on their behalf because it's coming directly from the person. Families with loved ones who die in ICU report having post-traumatic stress. Conflicts over treatment limitations can also, by this study, be traumatizing. A common cause of distress among families and teams, more so for nurses by another study, these sort of conversations around goals of care. Such families and clinicians, I would say, are often stigmatized. So sometimes we'll have clinicians that will align with a family that's asking for things that the rest of the team might say, why are we doing this? And we often say it, especially in critical care environments. I would add that's, right, so we've already talked about that there's less distress when patients make these requests for themselves. So the learning objectives for the talk quickly is to explore the possible causes for patients and families to want everything medically available, contrary to clinical recommendations otherwise. To empathize with and reduce stigma towards such patients and families. So I'm not trying to, yesterday at the talk that I gave at another facility, someone said, we should build rapport with families to try to make them susceptible to our ideas. And so I kind of push back against that word because, and we sometimes use the word malleability when it comes to substitute decision making. We're trying to develop a rapport so that we can have the most robust negotiations around treatment proposals as possible. The word susceptibility sort of, there's power embedded in that, but it's mostly from our side. And often in such conversations around goals of care, we're sometimes accused of pushing a particular pathway. So this is all in the service of what is it that the patient would want for themselves and what is most appropriate given the clinical context. Also, I want to, we'll do our best with time to get to some practical strategies and legislative guidance for healthcare teams to cope with such cases and in assisting such patients and families in their decision making. The first part of the talk, we're going to be looking at what the literature says about such requests. Second part of the talk, we're going to look at what I've seen in my clinical experience with regard to this. So one study gives 4 reasons for these, possible reasons for these requests. One is inaccurate or biased physician judgment. Clinician bias, they say, based on age or personal beliefs on the part of clinicians. There can be a reaction to such statements as, well, your mom is 90. And then there could be pushback that, because that is quite an ageist statement and not the basis for good decision making or treatment proposals. Inappropriate judgments of quality of life. So I often rail against, teams or clinicians saying, your loved one has low quality of life, because that actually is determined by the person or people who know them best, rather than superimposing this. I think a better way of approaching this is to say, what do you think is the quality of life right now compared to before, or how has it been changing for your loved one because they know the person best, rather than us making judgments. And also, by doing that, we might make people react, and then there might be overextended treatment requests. There might be apparent abrupt changes in the goals of care that lead to such requests, a lack of understanding of the burdens or relative inefficacy of treatments. There could be stress on the part of decision makers. We're very familiar with that. Denial that the person is reaching the end of life or actively dying. One family member the other day said back to a clinician who said, your loved one, it takes courage, and we need to say it, we need to be frank at times and gentle at the same time to say, we think that your loved one is dying. They might be hearing it for the first time. But the loved one said, well, everyone's actively dying. But we mean, which is true, but we mean something very, very specific. There's a definition that we have, and the definition might be variable, but there's certain things that we mean when we say actively dying versus all of us are slowly, of course, progressing towards death. A change in approach from curative to palliative, and suggestions towards such can cause such treatment requests as a reaction. So I often find that even broaching code status conversations and broaching goals of care conversations is seen as an affront by some people, that we're doing something wrong by broaching this issue, that we're making a statement also that we might want to hasten the person's death, which is not where we're coming from. We need to have these conversations, obviously, to prepare for future things that might happen, such as a sudden or, a gradual decline on the part of the person, to ensure that we're doing right by the person according to what they would want for themselves, if they could speak up for themselves. Efforts to obtain consent for treatment limitation is similar to what I just said. There could be sustained disagreements, often coming from requests to limit or withdraw treatment. So suggestions like maybe we should remove this, maybe we should remove the tube feeding because there's not overall benefit, and so on. Maybe we should remove the vent. I don't think I have vented patients here, but there's many different contexts we can think of where we might say we're suggesting for the overall benefit of the person that's overly burdensome to have this particular thing, maybe we should contemplate stopping that thing. Also, values-based disagreements. There could be religious or personal reasons on the part of families and also teams that could cause tension. I have a whole section in this talk on different religious traditions, which I'm just going to skim over lightly, do actually a deep dive in some of the traditions, but again, you can look at the slides afterwards if you want to know more about it. You can also get in touch with me afterwards if you want to talk more about it, and there are citations throughout the slides. Stats, I would say, deploying stats like in these circumstances, this often happens. It can actually backfire, I find, because if we say there's a slim to little chance of your loved one to emerge from unconsciousness or for them to have a meaningful recovery, families might say, well, even if there's a slim chance and they latch onto that, then we want to go for it anyways. Even if it's a 0.00001 chance that they might wake up from some, say, insult to the brain, they want it. There are other contexts where I think that actually statistics and research can be very helpful, and I'll mention that as we go along. And also, some people, whether it's religious or not, might have a sanctity of life, or what we might call a vitalist position, where life is the most important thing above all else, even if the person can't interact anymore. Another study says that for treatment requests like this, it might come from a lack of prognosis, misunderstanding a diagnosis, or unrealistic optimism. So I'm going to quote this study. Many patients reported either not being told their prognosis, or were found to misunderstand the status of their disease, the aim of their treatment, and their prognosis. We find this in research studies too, where people think that actually they're receiving treatment when in fact they're receiving a study drug. Unrealistic optimism. They often overestimated their chances of cure and expected survival, which has been shown to influence decisions to have active treatment. So here's one example of many of misunderstanding a diagnosis. I also have a section in this talk on the very recent brain death cases, the McKitty case and the Wananu case. One was from a Christian family, one was from a Jewish family. In both cases, they said that their religious tradition didn't recognize brain death as death. But in the McKitty case, initially what they were saying was, we don't believe that our loved one is brain dead, despite 3 independent physicians determining neurological death. So from this study, and it's a huge sample group of 1,351 people, there's a pretty much even split between people that think that someone that's been determined to be brain dead is as good as dead or dead. But there's still a group of people that think that the person is actually still alive. And again, I'm not going to go deeply into the religious traditions, but in the Confucian tradition, which is actually heavily influential on other religious traditions in the Chinese context, Taoism and Buddhism, for example, brain death is absolutely not meaningful to them because they don't see a distinction between the mind and the body, which is fascinating. Another study reinforces this unrealistic optimism as a potential cause for such requests. Patients, this is from the study, patients with metastatic colon and lung cancers overestimate their survival probabilities, and these estimates may influence their preferences about medical therapies. So I would say without a prognosis, it's very hard for anyone deliberating medical treatment, whether it's a patient or the SDMs or a family in collaboration making a decision together, to properly do a benefit versus burdens analysis, risks and benefits analysis, or to reframe their goals of care, maybe moving more towards comfort and away from active treatment. And their hopes for the future to the changing context, it's very hard to do this without a clear prognosis. So this is one of my, and the studies reinforce this, it's a key recommendation is to make sure that the prognosis is made clear and in an ongoing way because this can change over time too. Of course, we know that prognostication is fraught at best. It's a combination of science, educated guesswork, but it's very important, I think, again, and here's where I'm saying sort of the opposite of what I said about stats earlier. I think it's important at times to deploy research that's relevant to the decision being made. So, for example, there's a lot of research, and we often use this in discussions with families around advanced dementia, and there being not much overall benefit for such people as they're reaching the end of life to have artificial feeding. It helps with feeding discussions. Statistics in the critical care context, often we say, families will ask, how long is enough time to determine whether the person might recover from unconsciousness? And often we say, well, you know, we have a pretty good sense after a week or 2 weeks, and this seems like a very short amount of time to most people. But that's from clinical expertise that in general, and of course nothing is 100%, so again, many families latch on to this, say, well, even if there's a small possibility, and often what happens, and this will come up later in the talk, families will say, well, we had a loved one who emerged from a brain injury, and actually they're doing great, and that can definitely influence how they look on the current situation, for better or for worse, usually for worse in my experience. And clinical expertise is also crucial input in decision-making around such decision-making. Another major area that's looked at in the literature is maintaining control as a coping mechanism. So this is from one study. She, the wife of the patient, acknowledged to the team that because of her helpless feelings related to the patient's disease and prognosis, she felt this was the last element of control, the decision-making, that she maintained. It's not uncommon for nurses and team members to mistakenly see this as selfish and not as a coping strategy for the family. It seemed to the team that she perhaps did not understand the terminal nature of his illness and the recommended path of a comfort-directed plan of care, which then led to feelings of frustration and hostility towards her by staff. So this is part of my intention of doing these talks is so that we can empathize, and it's not to necessarily, I think we need to change the way that we approach such supports for families and such decision-making. But this isn't to say that there aren't things such as denial or people making decisions because of their own values and beliefs and their own feelings, but it's to try to have a better understanding of where people might be coming from. Many people look at this as denial, but in fact it's a common way of coping or protecting oneself from the burden that is upon them. And I'm going to mention it later. I hope I get to everything, but I might as well say it now. I think it's very important not only to have unconditional positive regard when we're working with patients and families, despite the frustrations around such cases, but I think we need to empathize with them and explicitly say that, and even if we're faking it until we make it, if we're not truly sincere, we need to say at least, we really are sorry for what you're going through with your loved one, what your loved one is going through, and the burdens of the decision making. We need to recognize it, and it really helps build rapport, and it helps. They might never have been told that someone sees them going through this stuff they're going through because it is impossibly difficult. Some of us might have gone through it already in our own lives, but I don't have that experience of making decisions on behalf of a family member. It is a very, very heavy burden, and this is why some people often say to us, I don't think I can make this decision. I can't act as SDM because this decision is so tough. And there are ways to work around this. I actually sometimes suggest the Consent and Capacity Board, not as an adversarial last resort, but actually as a way, if someone's really stuck, and let's say there's no other decision maker, and PGT is Public Guardian and Trustee, actually everyone in Ontario has PGT as a decision maker as last resort, people like homeless people or people who don't have families. They're very reticent to make certain types of decisions. We're trying to work on that, for example, giving them full care plans that include a DNAR rather than just, here's a DNAR, can you consent to it? And they often refuse because they say it's a future decision, not a current decision, which personally I think is ridiculous because SDMs make this decision all the time on behalf of their loved ones for a DNAR, changing of the code status. We need to recognize the burdens of decision making and explicitly say that and support families through it. How can we help you through this? Having family meetings, offering spiritual care support, maybe getting an ethics consult, doing it in an interdisciplinary way. Another thing, again, because I don't think I'm going to get to everything, I'm throwing out my recommendations peppered through this talk as we go along. It's good to have a point person on cases that knows the case deeply and well and knows the family well. Sometimes clinicians fly in and fly out. Some are better at sitting down and spending time with families in a dedicated space, in a quiet place, with enough time. But and of course, there's the pressures of time for clinicians, and some are naturally just better at these conversations than others. There's not great training for, in medicine and nursing, I would say, to have these conversations, maybe better in nursing than otherwise. But having a point person like a social worker, a nurse that knows the patient really well, a primary nurse that's following this case all the way through, so that they know the nature of the case and they know the people involved. This can be very, very helpful. This is another fascinating study that one of our fellows found on social ritual. This study argues that some treatments, which are often categorized as medically futile, nevertheless have significant ritualistic value and serve important social functions in the process of dying. Medical futility, the study says, is often defined as providing inappropriate treatments that will not improve disease prognosis or alleviate physiological symptoms, or prolong survival. This understanding of medical futility is problematic because it rests on the final outcomes of procedures that are narrow and medically defined. In this study, Walker's expressive collaborative model of morality is used to examine how certain critical care interventions that are considered futile actually have broader social functions surrounding death or dying. So personally, I fall philosophically under what's called symbolic interaction. It's also under social constructionism, which resonates with this expressive collaborative model, perhaps situational or relational ethics, in which ethics are not normative or rule or principle-based, but based on context, socially constructed, and based on relationships. So the example that they use is CPR, resuscitation. By their take on interventions as social ritual, CPR distributes the burden of accountability among a team rather than on one clinician who says we shouldn't do something or we should stop now. And it's a demonstration when we do a code that everything that can be done was done, whereas there might be suspicion that something was left undone when death happened suddenly. So this isn't to say we should be always doing code. This is just to give another perspective on where families might be coming from. And so one thing we're working on at Lakeridge is not reversing code status during codes. So let's say someone was consented on their own behalf before they lose capacity or lose consciousness to not be resuscitated. Often it happens that the family will say, just do it for not the good reasons, and definitely not based on the appropriate standards of decision making, such as prior wishes, because it's been consented to already. We actually don't need substitute decision making. Under the best interest standards, it usually doesn't fit the clinical context. The person has not gotten better, usually in these circumstances, or has deteriorated. No good reason to reverse the code status. Yes, sure, please.
You don't reverse the decision in the middle of the code. Should a person want to be resuscitated, and then the family member is saying halfway through, no, stop.
Right. That's a good question. There's lots of things that go on during code. So let's say somebody crashes and there is a full code in place, consented to either by the person themselves or you would hope by the SDMs based on the appropriate standards. This is a very good question now because there's actually a new groundbreaking decision by the Superior Court of Ontario that if it is unlikely that CPR would work, or if it would not work, meaning it wouldn't perfuse the brain and the heart, that it actually doesn't have to be offered as a treatment. Now, the CPSO were waiting for them to revise their policy before what they had in their new policy, which was very weird, and it was actually hard to educate clinicians around this. They said that under those circumstances, unlikely to work and definitely wouldn't work. Let's say someone's chest is cracked open and we can't do compressions. They said that you don't need consent to have a DNAR in place or to not offer CPR, but you need an absence of disagreement. what might happen with this new decision, basically the decision was based on a case where clinicians didn't offer CPR under certain circumstances. And the court, this higher court in Ontario, found that they were not wrong in doing that. It's going to potentially leave more room for clinicians to actually enact DNAR under certain circumstances. The previous court decisions and the previous policy by the CPSO was trying to prevent unilateral DNAR orders by clinicians. So we're going to be in a very tricky period. It's very curious. It'll be very curious. We're very curious to see how the CPSO will respond. They'll either match this new finding, or, which will be even more fascinating, if they overstretch and actually require more than the law does. Which is still requiring an absence of disagreement under certain circumstances. So your question, is it permissible for an SDM to ask to stop during a code? So, again, it's hard in the moment because decision-making is frantic at that time. There's no time to deliberate. It needs to be still based, I would say, technically by the legislation based on the substitute decision-making standards. Maybe the person had a wish, okay, you should try to resuscitate me for a minute, but if it doesn't work, you should stop. So, of course, that would be very appropriate. Also, clinicians need to limit how long we go during codes, too. That's something that's captured in this new Superior Court decision and is captured in the CPSO. It's a good faith clinical judgment on how far to attempt a code. So I would say we would be less averse to stop a code that started as clinicians, as teams, than to start a code that we think is not going to be beneficial overall. But in terms of the technicalities of permissibility of such things, I think there are circumstances where it can be. In general, if a family member says stop, I think we usually do. Also, there are camps around whether families should attend codes or not. There are strong believers that families should. I think if families knew more about what codes are like, they would make different decisions. Actually, on our own behalf, we might make different decisions if we know what codes are like, because it's traumatic on the body. We know you really have to give it, and ribs crack. So some clinicians say this during these conversations, and as unseemly as it might seem, as frank and brazen as it might seem, I think it's important information, depending on the context. It might, if family is devastated and everybody's in tears, it's maybe not the time to talk about that, but there might be times when it's appropriate to talk about that. So this is just to say that, from a family's perspective, codes, families and we worry about guilt that SDMs are left with when they make decisions going forward. In doubt, did I do the right thing? There was a clinician I was with yesterday during a family meeting, and he kept saying, I think you're going to feel guilty one way or another, and it was about whether to stop bicarbs and TPN, and the person is actively dying. And kept saying over and over and over again, it's hard to remove guilt from this, but let us assure you, we know that not only are you meeting the substitute decision-making standards, which was something that I could affirm by watching how they were doing things, they were really doing their best to follow the best interest standards, but the team knew them very well. They were very sincerely trying to act on behalf of their loved one who couldn't act on their own behalf. We're real quickly running out of time, but so maybe I'll open it up. Are there any other questions? I want to make sure that there's time for people to ask questions so far. Next, we're going to go into some of my ideas in clinical practice that might lead to such overextended requests. Any other questions or comments so far? You can continue to interrupt me if you need to. 4 subcategories, philosophical or religious views, what I'm calling vitalists. It may or may not come from a religious doctrine or religious tradition. Mistrust of diagnosis or disbelief in medical findings. I find the disbelief or the denial of medical fact or scientific fact extremely difficult for all of us to deal with. Think of an example where we talk about an image or even show an image and say, there's a huge mass here, this is not looking very good. And the family might say, and it has happened, well, we don't know that's a mass. How do you know it's a mass? It's probably fluid. Let's try to tap it. And also the denial of the brain death determination in both it wasn't in the Wanano case, but in the Minikitty case, they just didn't believe it. They had video footage of the patient moving their limbs, which was explained by several independent neurologists that these were spinal reflexes and the person is actually not alive. both of those are very fascinating cases. The same lawyer represented both of those families in those two different brain death cases, which is also quite fascinating. Emotions can play into these decisions, as we know. Attachment, mom, we don't want mom to leave us. Anger, guilt, we talked about guilt a bit. Grief, I would add also denial to this, to as potential feelings that could lead to such requests. And incapacity, so I'll mention it now since we're running out of time, that if decision-making is fraught because the SDM, the highest-ranking SDM, we wonder whether they have the capacity to actually make decisions on behalf of their loved one. This happens a lot. We often sort of, in the sidelines, say we wonder whether the SDM actually might have some mental health problems or are intoxicated, something that might impact capacity. Mental health problems or intoxication or actually anything isn't determinative of capacity ever for patients or for SDMs, but they can definitely impact it. Many cases where the team feels that the SDM might not have capacity, and clinicians are skittish to do a capacity determination because they're not our patient. But I've been saying lately, more strongly, it's a legislative duty for clinicians to determine the capacity not only of a patient to make decisions on their own behalf, but to make sure that SDMs have capacity to make decisions too, because it's a requirement. There are three major things an SDM has to have. They have to have capacity to make a decision, they have to be available, and they have to be willing. So often the unavailability or the availability problem, we can't reach the person. Obviously, this makes sense. We go to the next highest ranking person on the hierarchy, and unfortunately sometimes this is we're only left with public guardian and trustee. The capacity piece, we can also bypass this person if the clinician has deemed the person incapable. But again, very skittish to do so, but it's the same test. Does the person understand the relevant information to make a decision? Does the person appreciate the reasonably foreseeable consequences of a decision or a lack of decision, which is personalizing the information that they may or may not have understood? That's it. We don't need a capacity assessor to come in. It's only very narrow circumstances a capacity assessor comes in, and it's not for treatment decisions. So I've been encouraging clinicians to make a call. Do they have capacity or not? And if they don't, what I recommend is we can bypass the person, but we have to tell them, we have found you incapable for this particular decision. It resets after this decision. Both with patients and SDMs, if we find someone incapable, it doesn't mean they're incapable forever and always. It's time and task specific. They might regain capacity. They might have capacity for a different type of decision, but not the particular decision at hand. And we tell them we're going to the next person on the hierarchy. Let's say it was a spouse, then we might go to an adult child. And there's no appeals mechanism, and they're often angry when we tell them this. They're very upset because they want to act as a decision maker, and they're doing their best, and they often are. They actually can make an application to the Consent and Capacity Board with a Form C, I remember it by candidate, to be considered as a representative for the person. Which is lower than an attorney for personal care, so it's not relevant if there is an attorney for personal care in place. And then during that hearing, the board will actually consider this person who wants to be appointed as a representative, they will consider their capacity. So that's something that they can do if they don't agree with the decision, the incapacity finding on the part of the clinician. So, again, I have a whole section on religion. You can see it in the slides, but basically we have the Semitic monotheistic traditions. I look briefly at one of the Indic traditions because there are non-theistic traditions. Often I kind of cringe when I hear people say, well, we're all trying to do the same thing in terms of our religions because we all believe in God. This is actually not a fact. Buddhism and Jainism, they're two ancient Indian traditions, and they are non-theistic. There's no belief in God. And then a fascinating case I've also already mentioned, Confucianism. What I will say is that often people deploy religion in their decision-making when we're helping them make decisions. There's no monolith of views in any religion, I would say. I'm a religious studies scholar, and I say this boldly and confidently because they're mostly multivocal, and even within the sub-lineages of various traditions, different adherents might have different views. They may or may not align with what is known as the orthodox view, and so it's very, very specific and unique to different people. There's evidence in each of the religions in general, especially the Semitic monotheistic traditions, that there are different views. Because there are different views, there is some room and some permissibility for stopping something that's been started in terms of treatments, not starting something that has not yet been started. And especially between Islam and Catholicism in particular, there's a special category given to, or a special treatment of artificial feeding and hydration. Some feel that it is a fundamental form of care, not a medical treatment. One way of looking at it as medical treatment is that it's something that we consent for. We don't consent for or require consent for someone to choose to stop eating or drinking by mouth. It's something that some people naturally can't do or choose to stop. My grandfather on my mother's side actually stopped, chose. He was still fairly well, but approaching the end of life and chose to stop eating and drinking. So there's room for interpretation is what I'm saying. If we, and I trouble this sometimes, I have a little bit of expertise that helps, but if families say, well, in our tradition it says this, sometimes we can poke the bear a bit and say, well, you know, there are different views within the tradition, and also we can ask, have you consulted clergy? And even with that, one clergy person's perspective from their particular sect or lineage might not be in alignment with all the other various views. Sometimes to say there are different views in this tradition can give permission for the person to consider alternate perspectives and alternate pathways. The courts and the Consent and Capacity Board don't look to whether a person is of the same religion as their family or aligns with the views of that or the normative views of that particular religion, but they look for long-standing, deeply held beliefs of the person. Because often we have families that say, we're Muslim, therefore our loved one is Muslim. And in many, many cases, there's actually, and it happened in the McKitty case, there's no evidence that the person aligned with their religious views and their religious tradition. In my case, I was brought up in a certain tradition, definitely don't align philosophically or in practice, even though I'm still influenced by that tradition. I don't belong to that tradition. I have very, very different views on, and different views on what I would want for myself too that might be influenced by my particular religious tradition. So that's something to keep in mind. We can ask the question, if they say, well, we're Catholic, we can ask, oh, so is the patient also Catholic? And then ask for some narrative proof or some examples to show that. And these appear in court and CCB hearings too, where it can either be demonstrated or not that the person aligned with that religious tradition. This sort of approach of the courts and the CCB resonates with a relatively new definition of what's called creed by the Ontario Human Rights Commission as something that inheres in the person, not in a tradition. So really, this is something that could be helpful in how we approach collaborating and supporting families in their decision-making. Also, patients and families might rely on what's called, by one study, positive religious coping to deal with the stress of their illness. And it's such people who rely on positive religious coping by this study are more likely to ask for or receive intensive life-sustaining treatment closer to death. So I'm going to, I made a general statement that there's room in all of these Semitic monotheistic traditions for not starting something or for withdrawal of something. In terms of nutrition and hydration in Islam, there's a principle added to sanctity of life, which is basically life is the most important thing at all costs, regardless of the level of consciousness of a person. They also have another principle of the duty of a Muslim to feed a fellow Muslim, which can also impact decision-making. I didn't mention this. I mentioned brain death views, that it's not meaningful in Confucianism. And again, you won't meet a Confucian for the most part, but it's very influential over time through all of the different Chinese religious traditions. There's a joke that in China you call a priest from one religion for one ritual, you call a monk from another tradition for another ritual. There's a lot of cross-pollination between the traditions in China and a lot of hybridity, you might say. But the principle of filial piety pervades Chinese traditions through Confucianism, and this might lead a family member to refuse ever withdrawing care on their parent out of this duty to care for the parent maximally based on filial piety. We've got 5 minutes left. The only thing I'll say about Buddhism, which is one of the ancient Indic non-theistic traditions, is that sanctity of life is not based on life being a divine gift, but on a non-violence principle. It's called ahimsa in Sanskrit. And by the ancient monastic texts, they leave room by one commentator for withdrawal, because for an action to be complete karmically, karma is the law of cause and effect connected to consciousness, something that we do now, positive or negative, will have positive or negative impact on our future, either in this life or in future lives. For removing something or not starting something that has not been started yet, one of the factors called effort is not there with that. It's an act of omission rather than an act of commission. So thereby, by one commentator, by the discipline code, it's permissible. But there are various views too. There's another view from another study. In the Thai context, one study, one case, because there can be different views within the Thai context too, that necessarily if one is doing something that will consequentially lead to death, one necessarily has a negative intention, which will lead to bad karma. I refute this because it doesn't allow for what we call the doctrine of double effect. This is from Aquinas. We use it in medical decision making, and that makes an action permissible if there's a foreseeable negative outcome, such as we use it in palliative sedation. We know that the breathing is going to be suppressed, that it might hasten death, but it's not intended. So foreseeable negative outcome, but unintended. To say that everything that we do is necessarily a negative intention and that we are intending to hasten death is inaccurate. It's just not the case. So I refute that. This was a case from the Consent Capacity Board that demonstrates how they operate in terms of religion, not just that religion inheres in the person. In this case, the person definitely was an practicing Orthodox Jew, but they had made prior wishes embedded in their power of attorney for personal care document that said that they didn't want to be sustained to prolong their death, and they wanted to receive comfort measures under circumstances where there wasn't meaningful hope of recovery. The family said, well, our mother is Orthodox Jew. We've also consulted with our rabbi. Therefore, we should do everything, and basically disregard what she had put in the document. And the board found in favor of the wishes in the document because they said she had capacity, and people are entitled to have wishes that don't align with the tradition that they identify with. Fascinating and an important case, and again, reinforces this. On mistrust and disbelief, oftentimes people doubt diagnostic findings or medical evidence. I gave an example of saying that a mass, they feel that it's something else. Not believing the clinical interpretation of someone who has expertise and training in medicine. Patients or families may think that there must be more that can be done. A belief that clinicians are hiding something that could be done, not offering it as part of the treatment possibilities, or unaware of other possibilities. Great example from one of our sites where a family member asked for something that they were calling IV oxygen. Never heard of it. And we told them it doesn't exist. And they said, well, it's because you're a small hospital and you just don't know about it. So that was a very interesting conversation. And actually, the conversation didn't go away. Every day for months and months, he was asking for IV oxygen. So thinking that there must be things that we don't know about or we're not offering. Families and SDMs often don't believe care team's claims that further treatments would be medically futile or not producing an overall benefit. And this disbelief may play a role in requests for continued life-sustaining treatment. Another type of disbelief is disbelief in prior wishes that were expressed by the person. This can happen in various ways, but this is another form of disbelief. I've had families say, even though it's in this document, they didn't know what they were signing, they didn't understand the language, and they weren't there for this, all sorts of possibilities there. Also, we have some family members when we have fractures in families, or at least disparate views between family members, like between a new spouse and children from a previous marriage, where there's one case where all of the children said they had different conversations that related to the particular case, that they wouldn't want this thing that we're doing. The spouse said, well, I've never heard that from him, and I don't believe what they're saying, and I actually refuse to go along with that. And that could be a case of non-compliance, where they're not following, because wishes can come from any source and be in any form. They don't have to be written out. The only principle that's important to note there is that subsequent wishes trump earlier. Anybody want to ask a question or make a comment, please? Antibiotics, does that come up?
I think it's really around feeding. As Ahmed had with our different levels of care. So, like, we have a patient who's going to be 106 in a week, and it's been a very long, difficult struggle just to get the son to agree that she would be comfort care only. Like 2 weeks ago, he finally agreed. So we were doing everything for her up until then.
Right.
So just, that's quite a common theme, just to try to keep people alive for as much as you can, even if someone could be for palliative care, is the last minute family saying, actually, no, let's actually send them out.
To another facility.
Yeah.
Yes. So does this happen a lot here?
It happens.
Last minute, yeah. And,
Yes. So does this happen a lot here? Last minute, yeah. And if do you do codes here? Like, I guess what I'm asking is, do you call 911 here? Like, do you have emergency transport from here?
Well, we do carry out code blues.
Right.
CPR and do up to a certain
Right.
level, but then they would get sent out.
Right, for other things like venting and stuff like that. Right. Yeah, I mean, in that case, it certainly can't only be the fact that she's old. I just read in Scarborough we have a 109-year-old and she's still doing her own shopping and cooking. I mean, it's amazing, right? But I'm sure there are lots of contextual factors, and I'm sure the quality of life is one of those factors that you're asking the family to consider in that decision making. Yeah. Yeah, and if we think about when people are going home, I think it's important to have conversations of what are you going to do if something goes wrong when you go home, if someone, for example, is going home to be palliated. Because so often even when people are being palliated, people are calling 911, and maybe absolutely something that the person wouldn't want to go back to hospital to do all the stuff again, the physical stuff and also being vented and all the ICU stuff, yeah.
And so I guess what's the recommendations for how to help mitigate some of these tough decisions? I mean, I feel that sometimes having conversations early
Yes.
with family with a really good physician and nursing staff, just staff having this really good conversation.
Yes. I absolutely agree. A clear prognosis is very helpful. I mentioned a little bit about structured meetings of good length with active listening, making sure that what is being said is understood, getting them to feed back what's being said to them, because we actually often, because of want for time or lack of skill, we actually don't do that. We need to do that more. Again, I think it's important to recognize the difficulties, to feel with them. This often gives families permission to feel during these meetings. And it could be uncomfortable for us, and actually we might be very averse to being around catharsis or experiencing emotions ourselves, but I think we need to be in that fuzzy line with them to a certain extent. Another thing we can do is offer time-limited trials for certain things that they're asking for. I also distinguish between what is clinically possible or clinically indicated and what is clinically recommended. So it's like, yeah, we could put a G-tube in, yeah, and actually this is what we would do normally under these circumstances. But we're not thinking that that would be of overall benefit. We're not recommending it. I think we need to tease out the distinctions between those two things too, and saying, maybe if we start this, let's try it for a week, but then let's put a hard stop on that if we don't see improvement and things like that. I think that can be very helpful. Clarifying who the SDM is can be very helpful too, because we often have different views in a family. And this isn't to sort of like work the system, but it could be that we're not actually talking to the person who is the SDM. So it's very important always to clarify who that person is. And the person who is the SDM, again, for better or for worse, they could have a more rigid view than the person that's been the spokesperson or acting as SDM, but not actually the highest ranking person. And sometimes the highest ranking SDM defers to someone else who's louder, and they just do whatever they want, even though the onus is on them. So technically what's happening there is unwillingness when they defer. They're allowed to defer. People don't have to act if they don't want to as an SDM. That's another thing. And here too, and some studies reinforce this too. Early and often conversations. I think as soon as people come in, we need to have code conversations regardless of their status. We often don't when people are fairly well or doing okay. I think it's really important to do that because, as we know, things can change in a heartbeat. No pun intended, but yeah, things can change quickly. Yeah. Thank you for that. Yeah. Any other questions or comments? Thanks a lot. Thank you so much.